All right, let's get right into it. Today we're tackling one of the most stressful situations you can face in medicine: how to manage a patient with a suspected unstable cervical spine. This is one of those areas where every single move you make, every decision, can have absolutely life-altering consequences. The fear of causing more damage, of causing a secondary spinal cord injury while you're just trying to secure an airway is very, very real. It's shaped how we do things for decades. But the big question is, has our practice actually kept up with the latest evidence? Let's break down what the science is telling us right now. And make no mistake, this is not some rare, once-in-a-career event. In Europe alone, we're talking about over 30,000 people suffering a traumatic spinal injury every single year. So the principles we're covering today, they are absolutely crucial for anyone working in the emergency department, in trauma, or in critical care.
To really get our heads around this, we're going to break this explainer down into 4 key areas. First, we'll tackle that initial high-stakes airway challenge. Then, we're going to get into the new rules for intubation, fresh from 2024. After that, we'll explore what happens when the body goes into shock. And finally, we'll look at the critical long-term complications you need to be aware of.
So let's start right at the beginning. Before we even touch an airway device, we have to ask, who is the patient in front of us? Just knowing the common risk factors can immediately raise your index of suspicion the second they come through the door. Well, you've got 2 classic patient profiles. There's a peak in young adults, usually males, often linked to risk-taking behavior. And then there's another peak in older adults, where falls and already existing degenerative changes are the big culprits. On top of that, alcohol or drug use is often in the mix, and car crashes are still a major cause. The takeaway: when you see a patient who fits this picture, those mental alarm bells for spinal precautions need to be ringing loud and clear. Okay, now for the real core of this guide: intubation. And this is where things have really changed, thanks to some major new guidelines published in 2024. These are pretty much the modern rules of the road for securing an airway while protecting that fragile spinal cord. First things first, the simple stuff. For years, people debated the best basic airway maneuver. But now, the evidence from cadaveric studies, where they can measure spinal movement with incredible precision, is pretty definitive. A head tilt chin lift causes a ton of movement in an unstable upper spine. A jaw thrust, on the other hand, causes way less displacement. So the recommendation is clear: jaw thrust is the way to go. Now for the intubation itself, the new guidelines give us this really clear 3-step playbook. Step 1, get the front part of that hard collar off. It makes a huge difference to mouth opening and your view. Step 2, video laryngoscopy. This isn't just a nice to have anymore, it's now the recommended first-line technique. And Step 3, have an adjunct, like a stylet or a bougie, ready to go. It's been proven to boost that all-important first-pass success rate. And the evidence backing video laryngoscopy is just overwhelming. I mean, compared to the old-school direct laryngoscopy, it gives you a much better view of the vocal cords, it causes less movement of the cervical spine, and critically, it results in a much higher rate of getting the tube in on the first try. And in this situation, that is everything. This brings us to a really interesting point about something that's been dogma for decades: manual inline stabilization, or MILS. We were all taught that it was mandatory, but the new guidelines are pointing out that not only does MILS often make your view worse, there's actually shockingly little evidence that it prevents secondary injury. So what's the new advice? You should have a very low threshold to remove MILS if you're having any difficulty with the intubation. Okay, so the airway's secure, now what? Our focus has to shift, because a high spinal cord injury isn't just a broken bone. It kicks off this catastrophic chain reaction of physiological changes that affects the entire body. Let's dig into what's actually going on here. The first, most immediate threat is something called neurogenic shock. This tends to happen with injuries above the T6 level of the spine. What's happening is the injury basically cuts off the connection to the sympathetic nervous system. That's your fight or flight response. This leaves the parasympathetic system completely in charge, unopposed. It's like the accelerator pedal has been cut and only the brake is working. And that leads to a classic clinical triad that you absolutely have to recognize for your exams. First, you get severe low blood pressure, or hypotension, because all the blood vessels go floppy. Second, you get a slow heart rate, or bradycardia, because the nerves that speed up the heart have been knocked out. And third, and this is the weird one, you get warm, dry skin, because all the peripheral blood vessels are wide open. That's the signature of neurogenic shock. But beyond the circulatory collapse, there's an even bigger killer lurking. Both in the immediate aftermath and in the long run, the #1 cause of death after a cervical spine injury is, without a doubt, respiratory failure. And just how bad it is depends directly on how high up the injury is.
A classic sign you might see at the bedside is what we call seesaw breathing. Think about it. The intercostal muscles between the ribs are paralyzed, so the chest wall is just floppy. When the diaphragm contracts to try and pull air in, the negative pressure it creates actually sucks the chest wall inwards while the belly pushes out. It's this bizarre, inefficient, paradoxical movement, and it's a dead giveaway of a high cord injury.
So now, let's fast forward a bit and look beyond that initial crisis. Just because the patient has survived the first few hours doesn't mean they're out of the woods. As anaesthetists and critical care clinicians, we have to be on the lookout for serious complications that can show up days, weeks, or even years down the line.
First on the list is the huge risk of blood clots. You've got a perfect storm. The patient is immobile, and their blood vessels are slack, causing blood to pool. The result? The risk of developing a deep vein thrombosis is a whopping 3 times higher in these patients compared to other trauma patients. That means preventative treatment isn't just a good idea, it's an absolute non-negotiable.
Next up is a really dangerous condition called autonomic hyperreflexia. This can happen after the initial shock phase is over in patients with those high T6 and above injuries. Basically, a simple painful stimulus below the level of the injury, something as simple as a full bladder, can trigger this massive, out-of-control sympathetic nervous system response that can actually be fatal.
The signs are really dramatic, and you have to know them. The patient's blood pressure will shoot through the roof, but their heart rate will actually go down in response. They'll complain of a pounding headache, and you'll see them sweating profusely, but only above the level of the injury. Below the injury, their skin will be cool and blotchy. Recognizing this is a true medical emergency.
Finally, let's just touch on a bit of history, the steroid controversy. Back in the 90s, the NASA's trials suggested that giving massive doses of steroids might help with neurological recovery. But there was a big downside. It led to a major increase in serious complications like sepsis and pneumonia. So because of that risk, the practice is no longer a standard recommendation in many places, including the UK. So, as we wrap this up, let's leave you with a thought for the future. We've seen practice shift dramatically, moving away from things like MILTS and direct laryngoscopy towards a much smarter approach with video laryngoscopy. The question is, what's next? With technology getting better and better, could we one day get to a point where we can manage these airways with literally zero risk of secondary injury? It's a pretty exciting thing to think about. The information we covered on airway management today is really centered around the fantastic new multi-society guidelines from Wiles and his colleagues, published in the journal Anaesthesia in 2024. I highly recommend you check that one out.
And for a really clear, in-depth look at the pathophysiology of shock and those long-term complications, the 2009 review by Dinton and McKinley is still an excellent, valuable resource. I really hope this guide has helped clarify this super important topic. Thanks for watching.